Good morning. Okay, wonderful. Good morning, everyone, to the Wednesday, May 11th Medical Advisory Subcommittee meeting. Sounds like we have a quorum, so I'll go ahead and call the meeting to order. And we can go ahead and start with introductions. Dr. Burley with the Monterey County EMS Agency.
EMS Agency.
Kimberly Hernandez, EMS Agency.
Deborah Hopgood, EMS Agency.
Steve Brooks, EMS Agency.
Tina Nieto, Law Chiefs.
Kathy Calderon, Madrid.
Mike Eslinger with AMR. Morning.
Nick Greenson with SVMH.
Morning, Jeff Warner, Program Director with CalSTAR.
Good morning, Will Nealon with Monterey County Regional Fire.
Okay, well, fantastic. And thank you everyone for being here. It's always a pleasure to meet with everyone. We'll go ahead and move on to public comment. Any member of the public may address the subcommittee for a period not to exceed 3 minutes on any issue not on the subcommittee's agenda. And Mac will listen to all communications, but may not take any action. So are there any items for public comment? Okay, hearing none, we'll move on to approval of past MAC meeting minutes. There's minutes that you have for the March 9th MAC meeting minutes, as well as the April 8th minutes from the AB 361 special meeting, and the May 4th MAC meeting minutes from the AB 361 special meeting. Hopefully, you've had a chance to take a look at those meeting minutes, and unless there are any corrections that need to be made, we can entertain a motion for approval.
This is Tina Nieto. I moved to approve the March 9th minute meetings, the April 8th minute meetings, and the May 4th minute meetings.
This is Michelle Kalinsky. I'll second.
Okay, perfect. We have a motion for approval and a second. Let's go ahead and take a roll call vote on approval.
Dr. Kalinsky.
Aye.
Dr. Hawthorne.
Aye.
Dr. Orchard. Don't think he's with us. Dr. Greenson.
Aye.
Christy Soboleski.
Aye.
Tiffany Wallace. I think she's with us either. Cassie Caldera.
Aye.
Carrie Campman.
Aye.
Will Nealon.
Aye.
Ben Hitchcock.
Aye.
Jeff Horner.
Aye.
And Tina Nieto.
Aye.
Okay, fantastic. Thanks, everyone. So the MAC meeting minutes from those dates have been approved. And that'll bring us on to correspondence. We have no specific correspondence, which brings us next to reports and EMS agency updates. And Teresa has an update for us regarding the EMS agency.
Thank you, Dr. Burley. There is a staff report attached to the agenda packet with some of the activities of the EMS agency. There are only two that I would like to highlight. One is that the EMS agency secured a grant to help offset some of the cost of training EMS personnel to administer the COVID-19 vaccine. Deborah did a great job at submitting our application and securing the funding. We were awarded 20,000. It is based on population, and we are distributing that to the agencies that have participated. We presented to the Fire Chiefs Association our proposed methodology for distribution. Everything seemed okay, so we're gonna move forward and disperse the funds. The other one is that the Emcc has notified all the LEMSAs that, excuse me, that as of July 1st, EMTs and AEMTs will no longer be able to administer the COVID-19 vaccine. We also sent out a memo last week. We didn't send a memo right away because there were some clarifications that we needed from the memo that the state sent to us. So we also presented that at the Fire Chiefs Association just to get some feedback and see what, if any, concerns there would be. But anyway, we wanted to report that here as well, just to highlight that from our report. I'm happy to answer any questions you may have.
Okay, thank you, Teresa. Much appreciated. And the next item on the agenda under reports is MOAC activities, and Deborah Hopgood has a report for us regarding that.
There is a written report attached to your agenda packet, just to update on the latest case data. The data from this past Monday, we're currently at a case rate of 10.4 per 100,000 with a 4.1% test positivity. So everything's been trending up just slightly. Luckily, we haven't seen a concurrent increase in hospitalizations. Large increase in hospitalizations. We were at 11 as of yesterday, which is a small increase. The number vaccinated have been increasing very slowly, just about averaging about 0.1% per week. So not much change there. Otherwise, I would mention two things. One, that if you or any organizations that you are a part of are in need of testing supplies, there are still testing supplies available through the Mohawk ordering request process. And then I would also say that the EMS agency has been participating in several after action reviews related to COVID. Many of those have been distributed out to the individual EMS provider agencies as well. And just a plug to encourage your participation in those. It's a really great opportunity to share your experiences throughout the COVID-19 pandemic, the lessons you learned, and then to sort of help shape best practices on the go forward. So there'll be some more information on those coming out, but I would encourage you to participate. That's all that I have, but I'm happy to answer any questions if there are any.
Thank you, Deborah. Excellent continued work on MOAC activities. It's been obviously crucial during the course of the pandemic. And as we start to ramp down a little bit, obviously, there'll be other things to occupy your attention as well. So thank you for your efforts on that. The next item on the agenda is ambulance patient offload times, and Kimberly Hernandez has a report for us for that.
Morning, everyone. There was a PowerPoint on APOD included in your agenda packet. APOD times in February and March throughout the hospitals were stable. So not much to report, but if there's any questions, I'm happy to answer them.
Thank you, Kimberly. That brings us to old business, and the first item on the agenda for old business is law enforcement requests related to blood glucose, jail, and medical checks. And Deborah has something on that.
Not a large update to report. Law enforcement had requested responses to several questions that they had related to these patients. We have sent those responses, and we are still very interested in arranging a time to discuss the processes for coordinating response to and the disposition of these patients. So we're still hoping to meet with law enforcement on these. Yeah, that's the extent of the update.
Okay, thanks, Deborah. And I'll let you continue with the next item, which is disposition of intoxicated persons.
Really the same update for that as well. So still waiting to meet with law enforcement and discuss the issues further.
Okay, and that brings us to the blood and blood product transfusion monitoring.
We're still interested in pursuing the expansion of the scope of practice, but we've had to place this item on hold due to a combination of low staffing and other projects that have taken precedence at this point. So we will continue to pursue that in the future, though.
Okay, thank you, Deborah. And the next item on the agenda is the 2022 Policy and Protocol Review Cycle, and Steve Brooks has a report on that.
Good morning. We are nearing the end of the 2022 cycle with the July 1 start date. Everything seems to be moving along nicely. We've distributed well before the April 1 intended time to send policies and protocols for training. We have those all distributed. We are currently working to verify that the app is being updated. Just received word yesterday from the app developer that the app is about ready for us to do our final review so that they can put it together and have it ready for distribution in just a few weeks. There are a couple things with the app that I'd like to highlight. One of them is that we will be changing up some of the drug calculators. You will find that they will be much more user-friendly and also very useful for pediatric cardiac arrest. So the cycle's moving along and we should be ready to go with everything updated on our website, in the app, and training by the July 1 start date.
Excellent. Thank you, Steve. Appreciate all of your efforts regarding the policy and protocol review cycle, as well as the rest of the team at the agency and all of our stakeholders in your contributions to making this a successful review cycle thus far. And we look forward to the next review cycle, which we're already starting to work on. So it's an ongoing activity, but thank you so much for your efforts. The next item is the MAC membership updates, and Deborah has something on that.
Yes, there is a written report in your agenda packet. We have 3 members and 1 alternate who have agreed to be reappointed and serve an additional term. Those are going to Emcc today for endorsement. We are also awaiting nominations for a total of 3 members and 3 alternates from the Monterey County Fire Chief and Chief Law Enforcement Officers Associations. And we have 2 new alternate members who we are waiting for some documents from. We're also recruiting for a vacant member and alternate to fill the role of a paramedic from the contracted ambulance provider. So our goal is to have all of those positions filled and in place before July 1st.
Excellent. Thank you, Deborah. And then Steve, do you have something on triage tag days?
I do. Karina, would you be able to pull up the info? So triage tag days. We had an MCI not so terribly long ago that we identified that triage tags were not used. There were a total of 10 people involved in the incident, and triage tags could have been very much beneficial for tracking of the patients, distribution of the patients, and basically identifying which patients were the most critical. So what we're trying to do with the triage tag days, and some of us have been around long enough to remember that we did this several years ago. And so just real quick, the reason we're doing this is we want to make sure that the reason that triage tags aren't used is because of lack of familiarity and a thought process that, oh yeah, we've got these items that we should use for something other than a train or a bus crash. So we'll increase familiarity and thought process for using them. We also know that if you don't use an item, you don't necessarily feel comfortable using it. So we're going to make sure that there's some training involved with this so that we understand how to use the triage tag effectively. Along with that, we use start triage here. So we'll make sure that we're familiar with start triage. And then lastly, we also want to make sure that we can track our patients from the scene of the MCI to the final destination. Usually that will be the local hospital, but quite often, especially as we saw several years ago with the Soledad bus crash, many of our critical patients were then subsequently transported out of the county. And we want to know where they went and what their disposition was. And so the nexus between the field and the hospital really truly is the triage tag and the triage tag number. So what we're looking at to do is a couple of days, maybe every 3 to 4 months, where we do a triage tag on every patient. There are a couple of patients we won't be doing it on. Obviously, we won't use them on patients that are determined dead because that just looks bad, like we're doing a toe tag or something. Prisoners, we don't want to give them something that they may be able to use, for their benefit, not the system. And then patients on 5150 hold shouldn't put a tag with a string around their neck. It just doesn't work well. So we'll be making sure that the tags end up at the hospitals, that the hospital then it has a method for putting the triage tag number with their patient record number, and then we should be able to track the patients from there. We'll be looking for the ambulance to be considered as a transport group supervisor to collect the transportation receipts so that we can then account for all the patients and make sure that everybody got a tag that day. As we do review, we'll do a QI review on this. If you could scroll down a little bit, thanks. We'll do a QI review on this so that we make sure we've gathered the tags, that we've used the tags correctly eventually. But really just to get started, just making sure we got them used, and we'll expand as we go along. Our proposed timeline is roll out training in July and start doing the triage tags in August. And then of course, December, April is how we're looking at it right now. All subject to change as we find we may have some difficulties, which we'll adjust to, but that's the general timeline right now. And then you see we've got triage tag. Everybody should have triage tags. They're a minimum stock item on the ALS and BLS provider stock lists. So if you find that you don't have triage tags, let us know. And finally, as we go along, the Ems Agency will be replacing the tags that are used, so we make sure that the stock is adequate on the vehicles. With that, open to questions. Thank you very much.
Okay, thank you, Steve. And that brings us on to new business. The first item on the agenda under new business is the 2021 EMS Agency Annual Report. I'll turn that over to Teresa.
Thank you. The agenda included a copy of the 2021 EMS Annual Report. We are presenting that to the Board of Supervisors next week to coincide with EMS Week. So there will be a resolution proclaiming next week EMS Week and giving some highlights to the Board of Supervisors on the activities of the agency. We cannot talk about the EMS Agency accomplishments without talking about our partners. So we want to thank you. We want to emphasize the fact that we appreciate everybody's input, your ideas, your feedback on everything that we do, your participation on these committees. We know that it is a lot of commitment that we ask from you. And we look forward to continuing to work with everyone and continuing to improve our system, because that is the ultimate goal that we have.
Excellent. Thank you, Teresa. Any questions on the annual report? Okay, and that moves us on to the next item on the agenda, which is nomination of an emergency physician representative to the Emcc. Steve?
Yes, the Emcc has a wide variety of representation. One of the seats on Emcc is for the emergency physician from Monterey County. And we've had Dr. Greenson serving in that role, and Dr. Hawthorne as the alternate. Both have served well, and we appreciate their service. However, due to, let's face it, they're very busy with lots of activities. They've determined that they would like to step down from the role as a physician representative on EMCC. So the process involves coming to MAC for nomination of a emergency physician to fulfill the role at Emcc. And Teresa, you have more to add.
Yeah, my apologies, because we didn't get to touch base, and I did get an opportunity to talk to both Dr. Greenson and Dr. Hawthorne. Dr. Hawthorne, I'm not trying to put you on the spot, but I believe that you were reconsidering and maybe willing to stay on as the alternate on our committee.
Yeah, we were talking about being an alternate. Yes.
Yes, thank you. So Dr. Hawthorne is willing to stay as the alternate, so we would need Dr. Greenson,
We would need a replacement for the seat. And then also we would need then a nomination from this committee for Dr. Hawthorne to be the alternate.
Dr.
Dr. Glenski?
Yeah, so this is the first that I'm hearing about needing a representation. So unless you guys sent something out and I somehow missed it, I don't think any of us have probably gone within our groups to try to identify candidates or interested parties. It always works best if we have that baseline of needing somebody so that we can ask people that are interested. That's how we found Sean, and he did a great job. So I think we need a little bit of time to put this out there, unless, like I said, everybody else has already done that and there's no one else. And if there's no one else, I'll take it. But I think we really should put it out to all the groups and see what comes up.
Dr. Kalinsky, so we do bring this to committee. We did that, as a matter of fact, when Dr. Greenson was nominated and Dr. Hawthorne were nominated. At the time, Dr. Greenson had reached out to us. He submitted his letter of interest to be the Emcc representative. And we have spoken to Dr. Hawthorne as well, asking if he would be interested. We feel the need, we wanted to make sure that we have the wide representation and to make sure this, Me Memorial was also represented. So the last 2 years ago, those nominations came here to MAC as per the bylaws. But you're right, I think that we did bring those in March when we announced the vacancies. At the time, we simply announced that, the terms were expiring and that nominations would be needed. It wasn't until after that meeting that we learned that, Dr. Greens and Dr. Hawthorne were looking at not continuing to serve on that committee.
Okay, so I guess what I'm asking is, do we have time to put out within our groups query if there's interested parties, or are you beyond a deadline at this point?
Well, the position, Dr. Hawthorne has agreed to continue as the alternate, and so he just needs a nomination from this committee for the primary position. We do have time. I mean, it can go vacant in July. I mean, we tried our best to fill the positions by June to make sure that everybody's seated on the committee by the July meeting when the term would begin. But
so I guess what I'm saying is in the future, because if we know, I mean, we're obviously all crazy busy, you're right, and it's really hard to take on extra additional activities. It's in the middle of the day, midweek, and we all got other things. But if you go to the base medical directors of each facility and the representatives for the receiving hospitals and tell us, hey, this person's not going to reappoint, then we can certainly put a query out and try to work amongst ourselves like we always have to try to find a representative, because it's crucially important. So if we have time, I think we can all put that out to our groups and see if anyone's interested. We have always tried to rotate between the groups and provide adequate representation from all sources. And like I said, I've done it a number of times. If you don't get somebody, I can do it one more time, but I'd rather have a chance to put it out there.
Right. So sorry about this on my end here. I actually just made the decision a couple of weeks ago, so I didn't realize that we had to have something together by this meeting. I'd be more than happy to stay on in whatever capacity until this all gets worked out. So to kind of smooth the transition, if that's doable.
Yeah, that is doable. I mean, we can, the positions can go vacant. We try not to let them go vacant. That's why we always start in March. We come to the committees to announce those memberships that are expiring. We also announce those positions that have remained vacant. We've done a really good job in the recent years to have most of the positions filled. I think that the only ones that primarily remain to be filled are alternate positions, but the primary positions, they pretty much all filled. Every now and then we will have gaps in that, while we don't like them, it's something that we can deal with as long as we get a quorum. Getting a quorum for meetings hasn't been a problem in a while. Thank you, Dr. Greenson, for volunteering to stay on, and thank you, Dr. Hawthorne, for willing to remain as the alternate. In this case, I think that all it needs is a nomination from this committee for Dr. Greenson and Dr. Hawthorne to remain in their positions on EMCC. And I'm not sure, Dr. Kalinsky, what would be the best way to disseminate the information, because we do bring it to committee in March, as Dr. Greenson said. We didn't really know that we actually were dealing with a vacancy until a couple of weeks ago. So
Yeah, no, I now understand. And usually we work this out amongst the base medical directors when we know that somebody's not going to be there or stepping down. So it sounds like it was just a slip up. And Nick, if you aren't able to do it and need somebody to transition, I think we can all put the information out to our group and see if anybody steps up, and probably have an answer fairly quickly.
That works for me. Yeah.
okay, so this will need a motion for the nomination.
I'll motion for it to stay with Dr. Greenson as primary, Dr. Hawthorne as alternate, until such time as we can identify a suitable primary to take over for Nick.
Jeff
Can
Horner.
I
also-
second my own amendment?
Okay, so thank you, Dr. Kalinsky, for the motion, and Jeff for the second. Can we take a roll call vote?
Dr. Kalinsky,
Aye.
Dr. Hawthorne,
Aye.
Dr. Orchard, don't see still, Dr. Greenson,
Aye.
Christy Soboleski,
Aye.
Tiffany Wallace,
Aye.
Cassie Caldera,
Aye.
Carrie Campman,
Aye.
Will Nealand,
Aye.
Ryan Alexander is the alternate for Scott Houchin.
Aye.
Ben Hitchcock,
Aye.
Jeff Horner,
Aye.
and Tina Nieto.
Aye.
Okay, great. The motion carries. Just for clarification, Dr. Greenson, will you be staying on at MAC? We're just looking for EMCC?
Yeah, no, I'll stay on a Mac. It's just for EMCC.
Okay, perfect. Well, again, your contributions are really valuable, and I just want to recognize how much time and effort you put into the EMS system in Monterey County. So thank you for that. Sounds like we'll still have you at EMCC for a while, but we appreciate all of your efforts. So thank you so much for that.
Well, thank you. I appreciate the appreciation.
Okay, well, that brings us to the next item on the agenda, which is emergency triage, treat, and transport, or ET3 AMR request to initiate a program in Monterey County. And Kimberly Hernandez has something for that.
So AMR, excuse me, AMR is formally seeking approval to implement emergency triage, treat, and transport, otherwise known as ET3, here in Monterey County. The program aims to provide greater flexibility to ambulance caregivers to address healthcare needs of non-emergency patients following a 911 call. And we also have Michael Esslinger here to go over it in a little bit more detail.
Great. Hi, everybody. Thank you so much for your time. One thing, if I can request, Alex Oste is actually, I think, in the gallery, and if we can promote him to panelist, we're going to ask him to do a presentation. But first, I just wanted to say, thank you for your consideration to implement the new program. It's basically approved by CMS. So today it's currently just designed for Medicare patients, but we expect that obviously to be expanded to other insurance options. So ET3, it stands for Emergency Triage, Treat and Transport. It allows for greater flexibility for care options for low acuity patients in a field setting. And I think it's a great program. It's it allows virtual access to a physician from the field. Currently our only options in the field setting is to either transport or AMA. And I think that having another option of flexibility for these low acuity patients that sometimes put a significant burden on the EMS system, I think is really significant. Giving them virtual access to a physician who can assess the patient, even write prescriptions, I think really is an important step. The other piece of it is that it is somewhat of an accelerated program in that it's a 5-year program that we did apply for and have been approved for, but the implementation actually has to go into effect by July 1st. So we are in a kind of a timely time frame. So anyways, if I can introduce Alex Oste, he is our clinical care coordinator and innovator actually in Santa Cruz County. We did implement in Santa Cruz, and I think that he can give you kind of a brief presentation of the program and also, just let you know how it's going. So I'm not sure if Alex is up there yet.
Yes, I'm here. Hi, good morning, everybody. Thank you for having me, and thank you for the intro, Mike. So it's a pleasure being here. And as you said, this is an innovative program by the federal government that we are very excited to have been approved for and be participating. We have 62 markets as AMR nationwide, and in California, Riverside and Santa Cruz have been the first 2 ones to have access to it. So let me share my screen with you. Okay, can you see my PowerPoint?
We can see it.
Okay, perfect. So ET3 is a federal government voluntary 5-year payment model by the Center for Medicare Services that, as Mike was saying, is able to provide an alternative for patients that have a low acuity complaint, but they still call 911 for their problem. And here in Santa Cruz, we have implemented the treatment in place model for right now, which brings an ED physician to the patient via our iPad or the patient's devices. So the main goals that we have for ET3 is to provide a patient-centered care so that the beneficiaries can actually access their proper level of care. For the past few years, we have all been telling people, you need help, call 911, we're here for you. But as we progress, we have realized that we are overcrowding our EDs and we are overusing our ambulances for non-acute complaints. So we are trying to encourage appropriate utilization of the services while still meeting the healthcare needs of our communities effectively. So as I was saying, AMR Santa Cruz and AMR Riverside are the first 2 in California to have implemented ET3 across the nation. And by July, it should be implemented in more regions and hopefully in Monterey as well. So why did AMR choose to participate is that we want to provide the right care, right time, and right outcome for our patients, improve operational efficiencies, and improve ED wait times by redirecting low acuity complaints to telehealth, and overall improving patient experience, not only from a clinical perspective, but also from a financial perspective. These calls that happen through the ET3 program are reimbursed to AMR at the regular Medicare rate minus the mileage. It is not gonna happen. And the patients get billed by Medicare only $85 compared to thousands of dollars that the regular ER visit would have cost them. So it's a win-win situations for both the agencies involved and the patients. The Et3 Visit Guidelines are very simple. As of right now, we devised a system for our paramedics to have a clear-cut proof of concept system that is based only on low acuity complaints and based on vital signs. I have, let me see, a better version here from the PowerPoint that I can zoom in if you guys want to see it. There should be also included in the packet for the meeting as well. So we arrive on scene as usual. We perform history and the physical exam on the patient, and then we determine their emergent and non-emergent need. Once that has been established, our paramedics will ask the patient if they're Medicare eligible, and if all the criteria is met, then they can ask the patient if they're willing to see the doctor with a few minute wait on their iPad so that they can get their questions answered and avoid going to the ER. Let me move this aside. Okay, so the treatment in place system works through the eVisit platform by Envision Healthcare. They have on staff 24/7 about 8 to 10 physicians on duty, and all these physicians are emergency medicine certified, and they're all used to work in EMS prior to going to medical school. So they're all very well versed in the challenges that we face in EMS. Prior to the medics initiating the call, they will also log in the system. We use Image Trend in Santa Cruz County, and through our computers, they're also being eligible to see what kind of criteria and what kind of complaint the patient has and if they meet it. Now, the payer network for Santa Cruz County has been Medicare for right now, but I'm very excited to announce that as of last Friday, I have received the green light by the Central California Alliance. So all those patients are now eligible for telehealth as well. So it's not just Medicare anymore. As of Friday, I managed to negotiate with the help of our business development department that Medi-Cal Central California Alliance patients are now also eligible as well. And going back to how the eVisit platform works is very simple. There is an icon on every AMR tablet that can just be clicked, and the medics just log in using their credentials. The call can be initiated using our iPads or by patient's choice, even on their own devices. If they have better internet or if there is any other issue, they can actually talk face-to-face with the physician using their own device. The average time that it takes for the call to be initiated and for the physician to pick up the phone, it's less than 2 minutes. And the average time on scene for these calls we've been seeing, it's about 15 minutes, but then it saves the transport time. So it's very simple for EMTs and paramedics to document the Et3 encounter with the visual visit. As I said, we use Image Trend, but the disposition is very simple. All they have to do on our side is to say that the patient was treated and transfer care to telehealth provider. Once again, they get a virtual visit eligibility requirement reminder here to make sure that the patients actually qualify. I had deleted here only Medicare. I have to update it right now for the Central California Alliance. I opened a ticket with IT, but that's about to be done. And once they do that, the call gets transferred to the virtual visit. It's very simple, very intuitive for both our providers and the patients. They just put all the patient information here. All the information that you see here is fictitious. They just click on Envision Healthcare. They do not have to worry about which pharmacy to select because the patient has the choice ultimately, while our ED physicians are actually able to prescribe medications. Once the review is performed and they make sure that the patient is actually connected, the telecall initiates. On the right side here, there is a reason that the medics have typed that the physician is able to see even before it picks up the phone, just to get an idea what the call is about to be. And not only we're able to talk face-to-face using the camera on the iPad and the microphone, but there is also the chat on the side where the providers can put down the phone number of the patient and directly talk to them, while the AMR crew can either facilitate the physician with the visit or getting ready for the next call. we are going to be on scene throughout the whole time until the physician tells us to clear. By the way, we're not going to leave before the call is over. Closing out the virtual visit is very easy, and it's a matter of selecting the checkboxes, stating that the patient was, their care was transferred to the telehealth provider. And we have a 100% QA on every ET3 encounter that I personally take care of. I review these calls with the crews once they're done. And overall, I've been getting very good feedback from all the parties involved. I've actually been contacting patients as well. They're very happy that this option is here. And we started letting the public know through social media events and through newspaper articles that have been released on the subject. So it's a win-win situation. It's a wonderful program that helps us with our resource allocation and helps the patient get the answer to the medical problems that they have. And at the same time, it doesn't crowd the EDs. And this is all from me. Does anybody have any questions?
If I can add, this is Mike, if I can add just one thing, is that we have been working with ESO, and ESO did indicate that they actually have kind of a ready platform that we could easily switch over and even modify to meet our needs. The other question that had come up was whether or not, for alternative languages, interpretive services, and they do utilize an interpretive service that has access to over 60 languages. So it's been very successful. Trying to think of any other.
Yes, it actually has been used, and we got updated that actually the new translator service that we use has over 200 languages now. So it's even more inclusive than ever. Contacting them takes an extra few minutes, but that's pretty much it. I see Michelle Kalinsky has a question.
Oh, yeah, thanks. Couple questions. It sounds like you said you're following up with some of the patients. What percentage have you followed up with? Do we have information on what percentages are showing up in the ER within the next 24 hours, outcome data, and those kind of statistics?
Yes, I have all the statistics, and none of these patients ended up going to the ER. 2 of them had prescription. We have the total of 6 calls, by the way, let me tell you that. I was able only to contact 2 patients. The others did not pick up the phone. I tried multiple times. I guess my number shows up as spam risk. I am not sure. But the 2 patients that I have contacted have been very happy with the service. I do have access to the Santa Cruz County health system. I'm able to look these patients up in the system, and I've seen that they have not visited the ER after the telehealth visit, or to date for that matter. So we had 100% reduction for those 6 patients to go into the ER.
And I'm sorry, your program's been in place for how long?
Since March 18th, I believe.
So just this last March?
Correct, yes.
Started not, okay, so you have a short duration of
Yes.
kind of processing and everything. I guess my next question would be, when you went through and implemented this, did you put in the other components of ET3 in terms of alternate destination and utilizing your in-county resources?
That process has to go through more of our business development side and partnership with the local hospitals. We had negotiations here with doctors on duty, and as far as I know, it's still processing, but that hasn't happened yet.
I should also.
Oh, go ahead.
I'm so sorry, but I can also help answer the question. I think at this point, we're not necessarily pursuing the alternate destination transport for Monterey County anyways, but it is something that we can definitely look at, and at a future date, we can, try to explore options.
Yes, and let me add to,
go ahead.
Let me add to that. We have been approved for alternate destinations already, so it's a matter of finding partnerships in both Santa Cruz and Monterey County. So the fact of the matter is, it's very easy for us to implement it, and there's already agreements in place, so we're already ready for it.
I believe AMR has probably done extensive analysis in terms of their goals for the percentage of patients that they would like to capture as they expand this program. Can you elaborate on that?
So I don't have the specific data nationwide. The goal is to reduce both ED visits and low acuity 911 calls by further implementing a community paramedic program or advanced care program in the future. This has happened in the eastern seaboard of the US with our AMR regions over there. And it's been working mostly for the reason of not having a transport unit go to these calls. But here in the West Coast, we're still in the proof of concept phase. As I said, we just got approved for the Central California Alliance. So we got 2 steps in the right direction.
And I'm sorry, you have no idea what the overall goal is in terms of what do you anticipate the effect on the system in terms of decreased transport?
Yeah, that is correct, mostly because it changes so differently between each county.
Mike, do you have an idea on what's going on or what you're anticipating for Monterey County after your analysis?
You know, honestly, I don't think that we know the specific numbers. I mean, clearly these are, you know, low acuity patients that typically would, you know, bill for denial or not meet medical necessity typically for transport. So I think that our goal is to, you know, address that small population of patients. But I think the numbers, you know, being very open would be very small. I mean, as you can see in Santa Cruz County, it's been very minimal at this stage.
Right, but you're only using Medicare right now, which, you know, it's a fairly significant population portion, but it's with just getting started, you know, it's actually the toughest one. You're going to have probably a significantly higher number of young, healthy people that are going to apply to this program as you expand into Central Coast and commercial payers. My next question would be, you mentioned the $85 Medicare charge. I'm assuming Envision is going to be billing for telehealth services. Do you know what those charges entail?
The $85 is the cost of the whole visit and the prescription, and that's the bill that the patients will get compared to the ED visit. Oh, it's only
So there is
$85.
physician-based charges, and AMR is going to be collecting the total charges for the Medicare visit that covers everything.
The AMR is only going to collect money from Medicare, and the patient is not going to pay AMR. We're only going to collect from Medicare minus the cost of mileage because there is no transport. The patient will be billed by Envision Healthcare only $85.
Okay, and so AMR is also getting reimbursed what amount on these visits, non-transport assessments?
Yes, that would be the Medicare rate that I'm not really familiar how much it is, but from my analysis with other regions, we are cost neutral at best.
And I think it's okay to state, I know that we had a meeting with Dr. Burley and also one of the medical directors from the program. And for the telehealth visit, I think the total was $87. $37 of that went directly to the physician. And on top of that, it should be made very clear that there's no incentives for the physician on recommendations. I mean, once we activate the call, they're compensated either way. So there's no incentivizing calls to Envision or anything like that.
Well, I mean, your incentive to do this is you want non-transport, and this is the mechanism you're using. Obviously, there's a concern with bringing in a large national group that is owned by KKNR, who also owns AMR. So, you know, this is actually a little bit of a concern in this way, but, you know, I think we can certainly consider it. You know, when we had talked previously, I mentioned that, you know, there are a lot of great resources locally that we can use. I know AMR is a huge national company and obviously owned by a very large private equity corp that owns both. So it's a little interesting, but I'd love to see stronger data before giving an endorsement.
Understood. Yes, ma'am.
Yeah, and I should also just, you know, point out that the program itself is not, you know, designed by, you know, AMR, GMR, or Envision. You know, this was something that came out of, you know, the Center for Medicare and Medicaid Innovation Services. So
Right.
it was,
No, definitely
something that was
understand.
developed.
But
And I do think,
if I recall, you guys, Medicare and Medicaid offered a wide latitude of options to approach and innovative things that you can use, including utilize a lot of local resources. And AMR took this and then placed it with services from another entity within the larger global corporation.
yeah, I mean, I can honestly state I'm not, you know, familiar with that, so to speak. But I do think that it is a significant program for us, especially when you look at, I mean, in the patients that we transport, especially with the payer mix, it's nearly 70% are Medicare patients. So I think it would be a significant tool for our field, caregivers to utilize.
Yes, absolutely. And it's also important for the patients to be treated in their own home. If they have a low acuity complaint, they get to see a physician right there and then within a few minutes, they get their own prescription. They do not have to go to the hospital. And most of these patients are not able to drive on their own, so they have to wait at the ER for a ride back, or maybe even another private ambulance has to take them home. So the significant cost savings on the patient side for me are the biggest benefit of this program.
Yeah, and I'm also aware that, community hospital, for example, has an option. And I think that these are things that we can explore in the future. Looking at other insurance groups and, other options for these patients. I mean, it's just starting with Medicare, but clearly, I think at some point, we would have to have some type of options for the majority of our patients.
Yes, as I said, we just started with the Medicare, but we are involved in trying to expand this program as much as possible. I'm working with other EMS professionals and other AMR managers in trying to expand this to Medi-Cal or Medicaid with the US Congress. So we have been talking to representatives and senators about this. I've been very involved both on the political spectrum to expand it and locally as well. And as I said, I was very excited to see we got the green light from Central California Alliance on Friday. So a lot more insurance are seeing the value of this, where they would just have to either pay the $85 or $87 that is, compared to the thousands of dollars of an ED visit and maybe even a gurney transport and ambulance BLS transport back home.
We have a couple of hands raised, Dr. Greenson and
Thank you. So a quick question. So is it legal to steer patients in different directions in a pre-hospital care setting based on insurance status? My understanding was that was not, a good thing.
Yes, it is legal, and we're just offering a new service to the patient. We're not steering them.
Okay.
We're not trying to sell a service. As I said, for us, we're not really selling anything. We're just letting them know that they have this possibility, and it's totally up to them to either accept it or refuse it.
Okay.
If
And
we're-
then, so I'm sorry, I'm a little confused about the relationship between AMR, Global Medical Response, and this physician consulting company. So are they both owned by Global Medical Response?
I do not know that. I'm not sure about it, but
Okay.
I know we have contracted in Vision Healthcare.
But so Vision Healthcare, but is the parent company for Vision Healthcare part of Global Medical Response? So it's all the same parent company?
Yes. Yeah. We're under the same
Okay.
umbrella.
This
Definitely.
doesn't strike you guys as looking very improper, as a self-referral bias and all these kind of things?
Not really, because they would be just using like a different ambulance. Like we have different services within GMR. We have multiple air services. We have different ambulance providers. So this is an extra service that we offer.
Okay, because, as a physician, if I steer a person towards my own, corporation or whatever, that would be considered illegal.
Not in this case. It's like as if we had to call one of our helicopters on scene from Reach or Guardian. Yeah.
It looks kind of a little bit problematic. Okay, so my second question is, so you guys get back into service in 15 minutes. So that means you initiate a call with this group. They do their history and physical over the phone, do whatever they're doing with the patient reaction or off the phone in a total of 15 minutes. That strikes me as extremely short.
That is the duration of the call itself. A lot of the patient evaluation happens before that, first of all, to meet the criteria. Yeah. The total on scene time, I've averaged it out for the ones that we have so far. It's 28 minutes and 34 seconds on scene time.
And are like the physicians integrated into our healthcare system though? Can they like refer patients to their primary care doctor and order tests? And because a lot of these patients need complex social services stuff too, right? I mean, can they have access to like case management? I mean, I don't understand what value they're adding, or are they just kind of rubber stamping it against medical advice kind of system here?
These physicians can provide referral, and if needed, they can even contact the PCP.
Oh, okay. So they have some kind of access to like the patient's medical record or something like that, figure out what the PCP is and have a way of like contacting them, ordering blood tests and
They would have to
diagnostic
ask that information.
services.
They would have to get that information from our crew.
But your crew doesn't have access to that.
But
do they have access
They can
to
ask.
their-
They can ask the patient directly.
Right. I mean, so these are the kind of things. I mean, it sounds like they're not actually providing any medical care, right?
They're answering to the 911 call and provide their medical advice. Now, if further care is needed, some social services or some
Right.
lab
I mean,
tests, they can still transport to the ER.
but that's the point, is like the 911 call happened for like a reason, right? Right.
Mhm.
So and usually if it's not like a medical problem, it's a complex social service like problem, right? And so, it doesn't seem like it helps the patient, right? If that's what the, primary issue was,
Yes,
if you're just
and-
essentially having them rubber stamp this and then,
Yes,
going
and
back
if-
in service.
And we train our providers to see those cases and not offer it to complex social cases, like you mentioned. This is for low acuity patients. The last one that we had this morning, actually, so it's 7, I just got an email about it. It looks like it was a COVID positive patient and the patient just wanted to get checked out. Vital signs were good. I haven't gone through the whole chart yet. I just see it on the corner of my eye, but it looks like the doctor was able to talk to them and just end the call there versus transporting to the ER.
Yeah. I mean, that sounds a little problematic from a medical care standpoint, sitting on my end here.
Yeah,
Right. I mean, I don't know, without going into medical comorbidities and stuff like that. I mean, that is somewhat of a complex, process there. Okay. So anyway, I guess I have some very large concerns would be the way to say that.
yes, I understand. I see we have 2 more questions.
Will Nealon?
Yeah, I'm curious if the teledoctors, if there's limits on what they can prescribe. Can they prescribe narcotics?
No narcotics.
Okay, that was my question.
Yeah, no problem.
And can I just ask a question? So I do want to just verify what Nick was asking. Does Envision have access into their standard kind of EHR? Because I think most their systems, or a lot of them, work off of like Epic or other things where they can actually access patient pharmaceutical records and things. Because if they're doing kind of telehealth COVID positive test to treat and things, I mean, Paxlovid has 5 million drug interactions and half these seniors don't remember what they're on until you get through their pharmacy lists and stuff. So do they have access to all these records?
No, they only have it from what AMR has on our records on our side.
Dr. Kalinsky, I don't think they're providing medical care. Right.
Well, you just said they're prescribing and providing medical care.
I mean, what kind of prescriptions do these patients get? I mean, they get a steroid cream or something like that. I mean, I don't think they're providing real medical care.
Well, for COVID, if it's high risk, I hope they're getting Paxlovid or something that's going to benefit them. And we're not just, saying, hey, your vitals are okay, stay here and not get treated.
I think that's what we're doing, but anyway.
Okay, and I see Ryan Alexander has a question as well.
Yeah, hi, Alex. I actually had a question for the doctors real quick, and I was wondering if there's a level of triage in the emergency room. If somebody walks in and has like an unspecific complaint, do they get an immediate workup, blood work, vital signs, everything, and then get triaged? Or is there a lower level of care that kind of the patients get triaged out of after vital signs are done and the patient gets, like, I guess, is there a certain level of care that the patient gets or assessment and where the patient kind of gets triaged and they're get dismissed from the hospital? Or do they usually, go into the ER, get vital signs, and then go straight into a bed?
So I can answer that only for CHOMP. We're a solely physician-led group. Every patient has an emergency medical screening exam that's performed by a board-certified emergency physician with a full clinical assessment. They'll only get labs if they're indicated by the emergency medical complaint. So obviously we're not going to do it on every ankle sprain or things, but all appropriate testing required by evidence-based best practice emergency care will occur. With a full assessment, we do not triage away.
Because the reason why I say that is running medicals where somebody does stub their toe, or we get a lot of parents that might overreact to a certain circumstance. They call 911 before they even have all the information, or maybe somebody even calls 911 for somebody where they're not on scene. And so we get on scene, and sometimes because of liability and we're not doctors, our recommendation is always that they, because it can't not be a recommendation, that they go get a $3,000 ambulance ride to the hospital, to the emergency room. It is only under a very unique circumstance where, the patient signs an AMA, because that does put, or it feels like it puts a lot of liability on our shoulders. So just from our standpoint, so having and I don't know if this is the correct tool. I know nothing about this. I've never heard of it before, but exploring other tools where a doctor could act as a consultation to maybe even a nervous parent or a nervous elderly person as one more, I guess, level of, communication or, idea process where this person can feel a little more comfortable with the doctor, kind of like when we make base, might be a good thing to explore. I don't know if this is it, but something to consider for us anyways.
Oh, and I agree with you. So, you'll look at almost every single private insurer, and if you've got a private healthcare, you probably have a big, bold flyer that came in the mail that gives you your access to telehealth, right? So this is available universally across all payers. The only people that honestly don't have access is really our marginalized population. It runs the highest risk of bad outcomes, not having access, having things missed, and they're the uninsured. So I don't have a good answer for them, but I do know when they come in, they get attached to social services. We give them the resources within the system. We have people help them with access to payer insurance. So there's a lot of services that happen in the background in our system to ensure that people have appropriate alternate access and alternate treatment places. It definitely needs to happen.
Thank you for all the feedback. We really appreciate it. I think that one, we need to remember that this is a pilot program. One of the things that we learned, at least from the situation in Santa Cruz County, is that there hasn't been a lot of patients that have gone through this program. So I think that we were looking at implementing this pilot program and monitoring it very carefully, really going for the lowest hanging fruit, if you will, and the lowest acuity calls that could for patients who could benefit from this service. So we are looking for your endorsement of the implementation of this pilot program, and then we can always revisit. We can come back and bring the data, just as Alex does in Santa Cruz County. We would be doing a QA with every single patient of all the calls, provided that we can hopefully get a hold of everybody and monitor that more carefully. Dr. Burley, anything that you can add to that?
Yeah, so thank you again. It's a robust discussion, and appreciate all the points that are being made and concerns that are brought to the table, many of which I had as well. But we've had the benefit of having had many conversations, and I spoke to the medical director of the physician group as well. I had some concerns regarding whether there were any financial incentives to not have the patient transported. Those sort of things, sort of looking for any red flags, and to me, it seems that there is a need for a service to help reduce the number of patients who don't require emergency department services and could be appropriately and safely treated on more of an outpatient basis via ideally their primary care team. But since we know that this is not a perfect world, and getting access to your primary care doctor is difficult, especially in the moment, there's a need for other services such as telehealth, and which is why patients often go to urgent care or contact a telehealth specialist. This sort of brings the telehealth emergency medicine board certified physician to the patient at the scene at the moment that they contact 911. There's, most emergency department physicians would agree that there's many patients who come to the emergency department by ambulance who are not having a medical emergency requiring emergency department services, but have a need for medical care. And so what this program tries to do is identify the patients with low acuity conditions that could be served in this way, and give them the opportunity to get their questions answered and to speak with a board certified emergency medical physician who is credentialed in California, and maybe avoid a trip to the emergency department, thereby serving the patient, but also serving the system in its entirety by reducing traffic through the ED that doesn't necessarily need to be there, reducing wait times, allowing the ED to focus on higher acuity patients, all of which seem like a needed service, especially in this country. So those are some of the thoughts that I had going through the evaluation of this program. Is this the perfect program? Is this the right program? I don't know, but I do think the need is there, and this seemed like a good opportunity to go through a pilot program and see how we do. It has been employed by Santa Cruz County, Riverside, and then also on the East Coast. It's had a longer sort of track record and with good results. So is sponsored by the federal government and Medicare, and so it has all of the pieces in place to be successful. And so I wanted to bring this before the committee as an opportunity for us to explore this, discuss it, and potentially try it out to see how it might benefit the citizens of Monterey County, as well as the hospitals, which are sort of perpetually overcrowded and have difficulty with managing all the patients that come through. So those are just my thoughts, and happy to hear additional questions if you have any.
Tiffany Wallace.
Hi, everybody. So I'm just a nurse. I'm not a physician, but I have seen this program in other counties, and it's very successful in terms of those patients who, and we see a lot of them down here at me. I'm down at me Memorial, who couldn't get into the clinic or couldn't get into their primary care doctor. So they're more than clinically aware that they're, of their own situation, that it's low acuity, but they really just want some reassurance and want someone to lay eyes on them. And for those patients, of which we see quite a few down here, this program I've seen be very successful in decompressing the ER of these patients that really couldn't get into an urgent care or a clinic and just need some reassurance. So anyway, just my 2 cents.
Thank you for that, Tiffany.
So I guess we have a decision before the committee in terms of whether we're prepared to endorse the program for the pilot rollout. And I know there's been a lot of questions and concerns, and if we're not prepared to do that, then that's okay. But I also don't want to miss an opportunity to roll this out and to give ourselves an opportunity to assess the program and see if it's a benefit to the county. So that's kind of where we are. Do we have would anyone like to make a motion for endorsement?
Yeah, can I make a motion to defer endorsement till the next meeting?
Is there any possibility to get the data that, for the systems that have been running this program and, have the full analysis available so that we can have kind of all the information we need, figure out what are the goals, where is this going in places that have it established, what type of models they're using, what is their outcome data, what do their misses look like, what other resources are needed so we can have a comprehensive evaluation before we implement.
Yes.
I honestly feel like 6 cases is not enough to even evaluate.
Yeah, if you're looking data from AMR nationwide, we can provide that.
But I would say that, you know, we would
Be
likely have to do,
beneficial.
we would likely end up having to do a special meeting because I don't think the timelines would, you know, allow it to get pushed beyond, you know, July or even June. Since there would be so many, you know, components that we would have to address.
Can you
What
talk
is-
about your timeline, Michael?
Yeah, good.
I think that the program to be eligible has to be functional by July 1st. So we would have to consider doing some type of special meeting to address those concerns and put that together for you in advance of that.
This is to be eligible for what?
To implement the ET3 program.
I don't get what the time frame is. There's a regulatory cutoff or a funding cutoff or.
Yeah, there's a regulatory cutoff that the program has to be functional by July 1st, and it's part of the 5-year pilot. So I think that if we're not implemented, and I get the specifics of that, but there is a hard date of July 1st as being the program has to be active in that county by that date.
And this is like a California law thing, or?
It's a federal program actually with CMS.
Oh, so if you don't start it up by July 1st, then you don't know when you'll be able to do it, essentially.
Well, definitely we would not be eligible for that for 5 years.
Oh, okay.
Yeah.
Well, we maybe should have looked at this earlier because it sounds like we don't have enough information to make a, intelligent decision.
So Mike, this is Tina. So I'm assuming that if we don't take any action on this, then we're going to miss that 5-year pilot program. And so and the funding that comes with it, obviously from the federal side. That also means that if they're looking at it for the next 5 years, then this is something that we wouldn't even be looking at in the county for at least 6 years. Would that be a correct assumption?
I think that would be a fair assumption that if we don't implement, unless there's any other provisions that are made, at some point in that window, it's hard to say. But, clearly, I think the parameters of the program today does require it be implemented by that date. And it's a 5-year study, which we were approved. And we did apply for Monterey County. But honestly, with the RFP and everything else that was going on, we were really not clear on, I think, if we were going, what components we were interested in implementing. We did have some preliminary discussions early on, but at this stage, I think that we're just looking at the telehealth option. But we would have to do a special meeting, I think, in advance of that if you wanted to look at that data.
And then Mike, the other question I have is that since it is a pilot program, and maybe you can answer this, is that because it's a pilot program, we could pull the plug on it, right? At any time.
Absolutely.
There was issues.
Yeah, and I think that even with the SO, I think it's a very, marginal fee, which we would be willing to take on. And I think that if, at any point it is a pilot, and if it was considered that, for whatever reasons, if you wanted to suspend the program, I guess that would be an option for certain.
Is there anything built into this in terms of feedback to this committee in terms of how it would be going? Which kind of patients have been served and their outcomes, some kind of a monitoring program, given that it is a pilot?
Well, definitely 100% of all of the patients that would enter that system, actually, there would be some, QA, QI. Ben Hitchcock, the clinical manager, and Rachel Nealand, our clinical supervisor, would actually, carry the task of doing 100% review of those patients. So I would expect that we would be providing, updates to this committee and also Emcc.
And Mike, just to verify, because I know they said that they had access to Santa Cruz County data and we don't have full data exchange at this time for all cases. Will you be needing any data from the hospital in terms of your review of cases as you're going through individual patients to see if they actually, went by private auto or cab or some other point?
Yeah, I mean, I can look at Alex to see what information he's looking at, but I know that we are looking at, the outcome data and looking at kind of what the final disposition for those patients were.
Yes, I do a full-on research on the health information online to see if those patients have ever been seen by any county facility, either hospital, urgent cares, or any other facility. So I do have actually access to the full county resources here.
Morning, this is Jeff
And
Horner.
you'll have several,
I'm
so
sorry.
so that we won't have to, like I'm just verifying, you have similar access across all facilities in Monterey to know if a patient was seen at a facility.
Yeah, I think we would actually have identical access, and I think that there's probably some detective work that Alex has to do that would, but of course, we would take on the best practices and interface with Riverside as well. But the answer would be yes. I mean, our goal would be to do 100% audit of all those patients.
Honor was speaking.
Jeff, did you have something?
Yeah, thank you very much. Of note, we have a special meeting already scheduled on June 8th for reconsideration of the AB 361. Would that be sufficient time for formal queries to be made and for Alex to be able to come back and present on that and potentially make a motion for a vote of acceptance or denial at that time?
I think that gives us an opportunity to have some further discussion, and for me, it was helpful to talk to the medical director as well of the physician group, who was able to answer a lot of my questions and give me a better picture of what it looks like from the standpoint of the physician evaluating the patient. So for me, that was very helpful. And so it might be an opportunity for us to get a presentation from the medical director and ask specific questions, since a lot of the concerns seem to be coming from the ED physician group. Ask specific questions to address those concerns. So if the committee is in agreement with that, I'm fine with that. June 8th is our next special meeting, and so and we could use that opportunity to have a longer discussion and look at whether we want to endorse the program before the cutoff date. Does that
Yeah,
sound?
we're certainly willing to, basically do some research and come back, and also maybe bring some other experts with us that can answer some of the other questions that we were not able to answer.
So why don't we take a motion to that regard?
So Jeff Horner, I'll motion that we table this and reschedule discussion for our special meeting already scheduled on Wednesday, June 8th, at which point that should allow for enough time for formal queries to be made and for Alex to present, along with Michael Essinger, any expert consult to answer the questions at hand here.
Dr. Hawthorne, I say second, and if I could also request any additional data a little bit ahead of time. I know it takes a bit of time to look through charts, graphs, look at methods, all that kind of thing. And a 20-minute meeting might be higher yield if we have already had a chance to look through this.
Right, any data from a national standpoint on some of the East Coast programs that have had more experience, a longer period of time with the program would be helpful.
Yeah, and any detailed drill down of like what information they have access to when they do these consults and how that's integrated with the local healthcare services and case management and stuff like that would be extremely helpful too, because I don't understand how the program would be successful without all that part.
So we have a motion on the floor. Do we have a second?
I'll second.
Okay, let's take a roll call vote.
Dr. Kalinsky,
Aye.
Dr. Hawthorne,
Aye.
Dr. Orchard, do we have him still? Dr. Greenson,
Aye.
Christy Soboleski,
Aye.
Tiffany Wallace,
Aye.
Cassie Caldera,
Aye.
Carrie Campman,
Aye.
Will Nealand,
Aye.
Brian Alexander,
Aye.
Ben Hitchcock,
Aye.
Jeff Horner,
Aye.
Tina Nieto.
Aye.
Okay, thank you, everyone. So the motion carries, and we will convene on Wednesday, June 8th at 9:15 for our special AB 361 meeting, and we will have further discussion and presentations at that meeting to further investigate the ET3 program rollout in Monterey County as a pilot program. Perfect. Thank you so much. Appreciate all of the discussion. And that will move us on to the next item on the agenda, which is the 2023 Policy Protocol Review Cycle. Steve Brooks has a report for us on that.
So as Dr. Burley had mentioned, we are already internally within the Ems Agency have beginning with the 2023 Policy and Protocol Review Cycle. We've identified 51 policies for this year of the 3-year cycle. We've also distributed a request for any policies that seem to need something before their regular review cycle. And the Ems Agency has also, and it's part of your packet, included the list of the policies as well as the proposed timeline, which is subject to adjustment as we go, but it's intended to allow a great deal of public comment and input and bring it to as many stakeholders as we possibly can. So the information's there in your packet, but if you have any questions about the cycle, be happy to answer those.
Okay, thank you, Steve. And the next item on the agenda is the impedance threshold devices.
And that's back to me. And the request from one of our organizations was to consider the use of an impedance threshold device, which, if I think most of you are familiar with it, it's a device that attaches between the bag valve mask and the patient, either through an ET tube or with the mask, which limits the amount of airflow flowing into the lungs during CPR. And with that, it's intended to create a negative pressure in the chest, which is to improve return blood flow, which is supposed to, again, help with the total blood flow of the patient during CPR. So the Ems Agency is considering this. We've been looking at some studies on the use of the device. We know that many field providers are interested, but the Ems Agency, quite honestly, is still looking at it because some reports do show a significant risk if it's not implemented correctly. And so that's where we're at. We're still looking at it. That's why it's a report today. We will be bringing back something to this committee in the future. But I will entertain any questions.
Okay, thank you, Steve. The next item under new business is AB 361 requirements for remote meetings. Deborah has something for that.
The committee needs to reconsider whether the findings necessary to continue meeting remotely are still present. And if they do find that, make a motion and
Okay, so we're looking for a motion then to continue AB 361 compliant special meetings and ongoing remote meetings for the Medical Advisory Committee.
Jeff Warner, I'll motion that we continue under AB 361 for remote meetings.
Ben Hitchcock, I'll second.
Okay, we have a motion and a second. Can we get a roll call vote?
Dr. Kalinsky.
Aye.
Dr. Hawthorne.
Aye.
Dr. Orchard. Dr. Greenson.
Aye.
Christy Sobolewski. Tiffany Wallace.
Aye.
Cassie Caldera. Carrie Campman.
Aye.
Will Nealand.
Aye.
Ben Hitchcock.
Aye.
Jeff Horner.
Aye.
Brian Alexander.
Aye.
Tina Nieto.
Aye.
Okay.
And oh, sorry, go ahead.
So yeah, so the motion carries. We will continue to meet remotely for medical advisory subcommittee, and we'll continue to have special meetings as needed moving forward to be in compliance with AB 361. Our next special meeting date is recommended for Wednesday, June 8th at 9:15 a.m. And we will also have our presentations and discussions regarding ET3 at that time. Was there a specific action for that, Deborah, or?
No, just to make sure there were no significant conflicts that we weren't aware of when we proposed that time.
Okay. So that moves us on to the next item, which is EMS System Quality Improvement Program and CQI tag. You have a report for us, Deborah?
Sure. There is a written report in the agenda packet. CQI tag met in February. Our other QI groups have not met since the last MAC meeting in March. At the last CQI tag meeting, we reviewed EMS's core measures and ketamine administration data for the first quarter. We will be reaching out to the agencies based on our core measures findings for some documentation changes. Essentially, our care is that we're providing, the quality of the care is not being well reflected in our documentation. So we have some advice and some kind of best practices for documentation that we'll be communicating out to the agencies to improve that for future core measures findings. We're continuing to work on expansion of HDE access and access to get with the guidelines. We've been working with CHOMP in particular recently. And last thing is that the base hospital physician orientation that Dr. Burley held for the county is now available on the EMS agency's website for anyone who may be interested in that. That's all I have. Happy to answer any questions.
Okay, thank you, Deborah. And that brings us to any future agenda items that would like to be recommended.
So I'm not sure if it's an agenda item, but I've now had 3 physicians contact me with concerns about ketamine use in the elderly. They seem to be having kind of adverse responses and just really are not liking the medication. I don't know if we need to look at that policy and maybe limit its use in sort of the extreme ages. You know, most of these people are like 70 to 80 years old. So just something to think about, but I just got another one.
So Dr. Kalinsky, if you could send us any of those concerns and specific cases to look at, we're monitoring 100% of cases in which ketamine is being utilized. So far, the data has been very good, and we haven't been seeing a lot of adverse outcomes. But if there's anecdotal reports or concerns about specific cases, if you could forward that to us for review, we'd be happy to take a look at that, and then we can just see if there's anything that needs to be adjusted in the protocol.
Just so you know, there's no adverse outcomes. The protocols were applied appropriately, or I would have sent them along as a UO. This is just patients' experience talking mostly to, getting back to their treating physician, their primary doctor. Very anecdotal again, saying that it was the worst feeling that they ever had. They, were dysphoric. It was just sort of, the ketamine adverse effect that you're not going to probably pick up that early, but patients started to experience as the drug took effect. So just something to think about. I don't know how strong and robust the data is on using analgesic dose in elderly. I haven't looked at individual studies, but I was surprised that I had a few of them come across now.
Right. Yeah. And I mean, obviously, as you know, like the elderly are prone to all kinds of potential things in terms of analgesia. It's very challenging, whether we're using ketamine or whether we're using narcotics or anything in between. So that's something that we always have to be careful of. But yeah, again, happy to take a look at anything you have. So feel free to send that to us if there's anything that would be appropriate for us to review. The next item on the agenda is announcements for good of the order. Any member of
Dr. Burley, I'm sorry,
Yes.
but it looks
Sorry.
like Will has his hand raised.
Oh, go ahead, Will, sorry.
Thank you, Dr. Burley. I wanted to see if we could get an update on the health data exchange into ESO from CHOMP and Natividad as well. Currently, we get the data from SVMH, but the data does not come through from CHOMP in ESO, and the data that we get from Natividad is limited.
We'll put it on the agenda for the next meeting. Thank you, Will.
Thank you.
Perfect. Anything else for future agenda items? Okay, that'll bring us to announcements for good of the order. Any member of the committee may make an announcement or comment. And Mac will not be discussing it, but we're taking action. But happy to hear any specific announcements for good of the order.
I have one thing, Dr. Burley. Just wanted to let the committee know, we've had some conversation about the agenda items that kind of cross over from one committee to the next. And we are trying to minimize those instances. Unfortunately, there are some items that have both a clinical as well as an operational component. And as we know, both MAC and Ops are subcommittees of Emcc. So the activities of MAC and Ops at some point are reported to Emcc. Because some of you serve on more than one committee, you do get to hear the information more than once. The agency is going to start working on putting together a matrix of all of the reports that are given to the committees and coming up with reporting frequencies and formats and try to minimize that crossover. There are things that look like the same item but are specific to the committee, like the election of officers, the membership. You'll see those same items on all three agendas, but of course they're unique to each committee. The Ems Agency Report, we want to make sure that we disseminate the activities of the Ems Agency widely. We want our stakeholders to know what is going on. So that's another item that you see at all three. We try not to go into detail at every meeting. But yeah, some of the things do cross over, like the Et3 program. It is one of those that you'll see in more than one committee because of the nature of that program. We're trying to get endorsement for the implementation. It's got clinical components, it's got operational components, but we are trying to minimize addressing the same items in multiple committees.
Thank you, Teresa. I also see that there's a report under announcements and good of the order for Homeland Security active shooter training.
There's a flyer for those courses which are upcoming in Monterey County attached to the agenda packet.
Perfect. And then also likewise for STEMI and Stroke Summit.
Those will be virtual meetings. There's also a flyer attached to the packet for those as well.
Okay, thank you. Anything else for good of the order? Okay, well, our next meeting date is Wednesday, June 8th at 9:15 a.m. We look forward to seeing you all then. And there's the next regularly scheduled MAC meeting is scheduled for Wednesday, July 13th at 8:30 a.m. And we'll be meeting by Zoom as well. So unless there's anything else, we'll go ahead and adjourn. Thank you all for your attendance, your discussions, your thoughts, and we'll look forward to seeing many of you at EMCC and also seeing you at the upcoming special meeting on June 8th. Thank you, everyone.
Thank you for having me. Have a good one.